Our entire goal is to think about what life is going to look like after treatment for that client. And so we have to have a culture that fosters that involvement with a client and that really promotes their well-being and actually giving them not only the tools but the courage to be where they need to be following treatment. Yeah. What are some of those avenues that you normally see in the residential care with your clients? I mean, there are some traditional avenues and there's some non-traditional avenues.
As a therapeutic consultant, families are turning to me. So the avenue from sort of darkness into the light of a residential care program, it can come at the time when the person is in the hospital. So it can be a call from a family member or a discharge planner from a hospital saying, okay, so-and-so is with us, and we can see that they really need more than just jumping all the way to outpatient care. They're going to need a longer stabilization process, a process that can help them really develop successful plans. You have also the person in outpatient treatment. Maybe they've been doing fairly well, but they're starting not to do so well. So that's where we'll get a call from a therapist or a psychiatrist saying, I really want to avert the need for a hospital care for this person. I'd like to get them into a residential treatment center to help them regroup, to help them sort of consolidate what they've already learned and learn more. And then you'll also get a call sometimes from a clinician like that who says, well, I've been working with Sarah or Johnny and they're just stalled. I know they could do so much more. They can come into the residential treatment program and really get to a much higher level of functioning and fulfillment.
It may be an overused phrase, but it really is filling a gap. Filling a gap between those who have only experienced, as you mentioned, the acute inpatient stabilization, and those clients who have only experienced outpatient therapy, many times, multiple times with failure.
In bringing in the gap concept, you also bring in the awareness that in that inpatient setting and sometimes in the outpatient setting, we treat people as sort of objects and we just treat a piece of them.
That's right.
But in the residential setting, it's 24/7, and we look at the whole person. So in addition to getting the best of science, the best of psychopharmacology, psychotherapy, the best of individual session, the best of group sessions, they're getting a whole experience. It's about good nutrition, sitting down with staff and with peers at meals, being able to go exercise, being able to be not just someone with a label that says I've got this or that diagnosis, but as a whole person who's beginning to define and re-achieve their dream. 24/7, under the eyes and with the support of expert clinicians, interacting with peers, with other staff, you get to see much more clearly what the diagnosis actually is. Quick story. You helped so much this young woman that came out of a psychiatric hospitalization with her first psychosis. She came out of that brief stay being labeled as a persistent schizophrenic. And here you were able to look at this young woman, realize that, oh, wait a minute, no, there was substance abuse. This was a substance abuse-induced psychosis, not persistent schizophrenia. You did great work with her here, and inside of a couple of months, she's on now to working and going to school, and she's not persistently psychotic. So we have to be so careful in labeling people with these diagnoses that can feel permanent.
They can.
They can.
And I think that is a great example of not only residential treatment filling the gap, but also it needs to be the right type of residential treatment.